I want to thank the organizers for inviting me. My name is Scarlatescu and I work in Bucharest, Romania. I don't work in neurosurgery, but mostly in major oncological surgery, liver transplantation and liver surgery, but also quite a lot in ICU. Actually, the topic of my first lecture is coagulopathy management in critical care, but I was asked also to give a few words about physiology of coagulation. Actually, we heard already about this from Sibylle, so we will just take one more time again some ideas. These are my disclosures. Actually, the process of coagulation was divided into successive steps, but mostly because of didactic purposes, because in reality, all these processes occur almost simultaneously. So when we have a vascular wall lesion here, the first thing that happens, we have vasoconstriction. And this is increased by the endothelin release from the surrounding endothelial cells. Then we have primary hemostasis. So the platelets start to act and they have adhesion, activation, aggregation, and in the end they form this primary platelet plug. During this time, we have also the activation of secondary hemostasis because we have the exposure of tissue factor to the blood flow, and we will have the fibrin clot formed. Of course, all these processes need to be stopped at one point. Otherwise, we will have this clotting extended beyond the vascular wall lesion, so we will have clotting all over the body. So we need for this some antithrombotic mechanisms. And also, once we have the bleeding stopped and once we have the vascular wall lesion started to heal, we need these clots to be removed, to be lysed, in order to restore vascular permeability. So this is, in a few words, the succession of events that is taking place in coagulation. Primary hemostasis, we know. Here the platelets play the major roles, and they have these functions of adhesion, activation, aggregation, but very important procoagulant function. And as you can see here, the platelets express on their surface many, many receptors, actually much more than in this slide. And actually the platelets are quite complex structures. So the first thing that happens is platelet adhesion. It means that the platelets become adhesive to this subendothelial matrix, especially to collagen and to von Willebrand. And actually this adhesion depends on the local rheological conditions, because if we have high shear stress, if we have arterioles, the platelets come here with a very high speed. So it is very difficult for them to stop and to become connected suddenly to this extracellular matrix. So this is why we have first connections are made between the platelets and von Willebrand factor. And these are unstable connections. They are formed and then unformed, but they serve to slow down the movement of the platelets and to make the platelets roll slower on the vascular wall, making possible the next adhesion between collagen and glycoprotein 6 on the surface of the platelet. And this is the connection that is actually a final connection which realizes platelet adhesion. Because after this connection is made, we have the process of platelet activation, which means that the platelets will change their shape, which means that they will release the content of the granules, and they have inside the granules, they have coagulation factors, and they have also different platelet agonists. And these platelet agonists, which are released, come and act on the surface of the platelets on their correspondent receptors. And they act not only on the same platelet, but also on surrounding platelets. So they serve to activate and to recruit additional platelets at the site of injury. And once we have these receptors occupied here, we have intracellular signaling, leading to increasing of intracytoplasmatic calcium concentration, leading to very important modifications in the platelets, meaning that the platelet will just flip its membrane, exposing some phospholipids, which are normally found on the inner side of the membrane. They will be exposed on the other side, of the outer side of the membrane, and this is very important for secondary hemostasis. Also, this activation of the platelets will lead to the modification in the shape of this receptor, and this is glycoprotein 2B3A receptor, which is found like this in the resting state. And once we have the platelet activated, it will stretch and will expose the binding site of fibrinogen, making possible the next step in primary hemostasis, which is platelet aggregation. So it means that more platelets are bound together by fibrinogen, which is bound to this glycoprotein 2B3A. And we obtain the primary platelet plug. So this is primary hemostasis. As I said, the platelets have very important procoagulant functions because they release from their granules, they release coagulation factors because they expose these phospholipids on the surface of the membrane, and this will serve for the secondary hemostasis. And also because the platelets can actually contract, shrink the clot and make the clot more stable to lysis. So they act very well for clot stabilization. Now let's move to the secondary hemostasis. This is the plasmatic hemostasis, so-called, and this is a list of the coagulation factors. As you can see, they are numbered from 1 to 13. Factor 6 is missing. And as you can see, they have different names, they have different structures. Some of them are proteins, some of them are enzymes, some of them are ions. As you can see, they have very different plasmatic concentrations from very low to very high, such as fibrinogen. They have very different plasmatic half-lives from very low to increased. Factor 13 has the longest plasmatic half-life. And they act like in a cascade. This is the coagulation cascade model, meaning that the activation of one coagulation factor will trigger the activation of the next one, and the next one, once activated, will activate another one, and this is how the model was described. As you can see, we have two pathways, extrinsic pathway and intrinsic pathway. Extrinsic pathway is short, having only two coagulation factors, tissue factor and factor 7, and intrinsic pathway is longer, having more coagulation factors. But both of them, in the end, will conduct to the activation of factor 10 to a common pathway. And factor 10, once activated together with factor 5, will cleave the prothrombin to thrombin, and thrombin will activate fibrinogen to fibrin, and also will activate factor 13, which will stabilize the fibrin clot. So actually, this is the model of coagulation. But we have several problems with this model. For example, this model does not explain some things that we find in the patients, like, for example, patients having deficiency of factor 12, which is at the beginning of the intrinsic pathway. Those patients do not have bleeding, but on the contrary, they are more prone to thrombosis. We might think that yes, because they have a functioning extrinsic pathway, so things can work. But actually it seems that from this coagulation cascade, these two pathways cannot work separately. For example, if we have hemophiliac patients which have deficiencies of factor 9 or deficiencies of factor 8, these patients still have functioning extrinsic pathway, but they still bleed. Similarly, if we have problems with factor 7 from an extrinsic pathway, we still have a functioning intrinsic pathway, but still the patients will bleed. So these problems are not explained by the coagulation cascade model. So this is why we have another model, which is the cell-based model of coagulation, which was described by Monroe and Hoffman. And as you can see here, we have a little bit more complex interaction between the coagulation factors and the cells. And in this cell-based model of coagulation, we have three successive steps: initiation, amplification, and propagation. In the initiation phase, everything happens on the surface of a cell which expresses tissue factor. Normally, this cell is not in contact with blood because it is found underneath the vascular wall. But once we have a vascular wall lesion, this cell will come in contact with blood, and in blood we have small amounts of activated factor 7. So this activated factor 7 will form a complex together with tissue factor on the surface of the cell and will lead to the activation of small amounts of factor 10 and also of small amounts of factor 9. And this factor 10, together with factor 5, will activate small amounts of prothrombin to thrombin, which is not enough to start to form the clot and to convert all the fibrinogen to fibrin. But it is enough to move to the next step, which is the amplification phase. It means that these small amounts of thrombin will move to the surface of a platelet in surrounding space, will activate the platelet, will activate also several coagulation factors on the surface of platelets, such as factor 11, factor 8, factor 5, and will move to the next step, which is the propagation phase. And in this time, everything is going on the surface of an activated platelets, on the surface of these phospholipids that we discussed about. And here we have already enough coagulation factors activated to form coagulation factor complexes. For example, this is the 10-ACE complex, which is formed by factor 9 and factor 8, leading to the activation of factor 10. And as we know, factor 10 together with factor 5 will convert high amounts, this time of prothrombin to thrombin, and this is the thrombin burst. This is the conversion of enough thrombin just to make the fibrin clot. As I said, we need to have a stop signal, otherwise we will have coagulation propagated into all the body and we will have microthrombosis everywhere. And these are the main anticoagulant systems in our organism: protein C system, antithrombin, and tissue factor pathway inhibitor. We have also other anticoagulant systems, but these are not so important. Protein C system is actually a very nice example to see the double role of thrombin, because thrombin, as you have seen, acts as procoagulant, but also thrombin can exert anticoagulant functions, like here. Thrombin, when it comes in contact with an intact endothelial cell, will bind to this receptor, which is called thrombomodulin, and in the presence of protein C, will activate protein C to its active form. And activated protein C, together with protein S, will inactivate factor 5 and factor 8, and in this way will inhibit the propagation phase of coagulation. So this is the anticoagulant effect of the protein C system. Antithrombin is the most important inhibitor of thrombin and also inhibits factor 10, and in much smaller amounts inhibits factor 9 and factor 7. And actually the action of antithrombin is quite slow, but when it comes in contact with heparin or with this heparin sulfate, which is found on the surface of the endothelial cells, the action of antithrombin becomes 1,000 times much quicker and will inhibit more efficiently thrombin. Tissue factor pathway inhibitor, this is something which is a peptide which is synthesized from the endothelial cells, and it is found on the endothelial cell surface and actually binds to tissue factor, to factor 7 activated, and to activated factor 10, and inhibits all these factors. So these are the major anticoagulant systems in our bodies. As we know, we need also to have the clots lysed, and this is mainly realized by plasmin, which is the main actor in this fibrinolytic system. And we have several activators of plasminogen to plasmin. And I just want to show you this slide to show you that in this fibrinolytic system, also we have activators and we have inhibitors. And in order to function correctly, we need to have a balance similar to the coagulation balance also in this fibrinolytic system. Now, about the coagulation management in critical care. If we think about coagulopathy, the first question that we ask is, what is coagulopathy? According to this definition, coagulopathy is a condition in which the blood's ability to clot is impaired. And this can mean two things, either bleeding or thrombosis. And in our ICU patients, actually we can see both of them quite often. And sometimes we can see them even in the same patient. So this is a special situation where these two go together. We have many, many causes of acquired coagulopathies in critical care. And if we think about them, we can structure them in some main categories. We can have them secondary to disruption of homeostasis in patients that have very, very severe hypothermia, very severe acidosis, or very low calcium levels. We can have coagulopathy because of deranged plasmatic coagulation, and this can be due either to medication, antithrombotic medication, either to excessive activation of coagulation, such as in DIC, or to excessive activation of fibrinolysis, such as in hyperfibrinolytic states. And the third main cause of acquired coagulopathy is represented by the platelets. And we can have here either platelet dysfunction, either a decrease in the platelet count. And if we look at this slide, you realize one thing, that many of these causes for acquired coagulopathies in critical care are actually iatrogenic, are due to medication, antithrombotic, antiplatelet medication, or are due to different treatments. For example, if we put our patients on CPB, if we put them on even on dialysis, on ECMO, on intra-aortic balloon pump, we expose the blood to extracorporeal circuits, and this will lead to activation of intrinsic pathway, will lead to platelet dysfunction and to decrease in the platelet count. So many of these causes are due to us, to our treatments. Now, talking about platelets, it is very often that critically ill patients have thrombocytopenia in ICU. And this is a study of mixed medical and surgical ICU patients showing clearly that approximately 1/3 of these patients had thrombocytopenia at ICU admission. And in the very first days after ICU admission, the platelet count is decreasing even more, and then it will start to increase. This is the normal evolution. This increase is sustained, but only in survivors. In non-survivors, this increase in the platelet count is non-sustained, and as you can see here, the platelet count is predictive of patients' outcome in ICU. Non-survivors will always have lower platelet counts compared to survivors. One cause of thrombocytopenia in ICU patients is surgery. And this is the normal evolution of a patient after surgery, after different types of surgeries. And actually you see that after surgery, we have a decrease in the platelet count, reaching the nadir in days 1 to 4 after surgery. And then it will start to increase, reaching the pre-surgery levels around days 5 to 7, and then increasing even more, reaching supranormal levels. And this change, as you can see, this swing in the platelet counts is very much outspoken, especially in trauma patients and in orthopedic surgery. This is why the trauma patients, after the first period, they have a high thrombotic risk, also because of the increased platelet count. In cardiac surgery, in abdominal surgery, we have the same swing in the platelet counts, but it is not so much outspoken. This is the normal evolution after surgery. But for example, if we have a surgical patient and in the second week after surgery, we have already the platelet counts recovered. And suddenly we see another decrease in the platelet counts, which occurs brisk in 1 or 2 days or even a few hours. Then we have to think of another cause, not think again that the surgery is to blame. This is usually due to immunologic causes, and we have to consider here either drug-induced thrombocytopenia, either heparin-induced thrombocytopenia, either thrombotic thrombocytopenic purpura. And if, for example, we see the platelet counts decreasing in a few hours after the patient received a blood product, we have to think about contamination of the blood product with bacteria, or that the patient actually received some alloantibodies against its platelet with this blood product. We have 7 main causes of thrombocytopenia in ICU. But the first thing that we need to see, we need to make sure that we really have thrombocytopenia, because it is very often that we have pseudo-thrombocytopenia, falsely low platelet count, due to different problems such as, for example, blood draw, such as blood clotting in the blood tube, and actually the patients do not have thrombocytopenia, and we start to think and look for something that does not exist. So the first thing is to make sure we really have thrombocytopenia. And we can, for example, ask from the lab to do this blood film assessment, and this is very easy. They look on the blood film and they confirm whether it is thrombocytopenia or not. If we have thrombocytopenia indeed, then we can look at these causes. Sepsis and DIC are quite frequent causes of thrombocytopenia in ICU. We will discuss about them in the second lecture. Massive blood loss and blood dilution, we know about it, it is logical. And then we have some very specific causes of thrombocytopenia which are specifically found in ICU patients, and we will discuss immediately about them. How do we investigate thrombocytopenia in ICU? Because we need to have a very structured approach. If we just ask chaotically for different blood tests, we might miss the diagnosis in some cases of thrombocytopenia. So we have to start with the beginning. Again, make sure that we really have thrombocytopenia to exclude, like, for example, the sample taken from the same arm where we have the fluid running, or any other simple stuff. Once we are sure that we really have thrombocytopenia, we need to do some basic investigations. And these investigations can be done basically in all the labs and are useful to exclude some very common causes of thrombocytopenia, such as liver cirrhosis, such as acute viral infection. And after running these tests, we already should have 1 or 2 diagnosis suspicions. And then we can ask for more specific tests of thrombocytopenia, like antibodies or measurement of ADMTS13. So this is my suggestion, to be very logical in your diagnosis of thrombocytopenia in ICU. Drug-induced thrombocytopenia is quite frequent in ICU patients because, of course, they receive a lot of drugs. And actually, it is a cause that we may forget about. We don't consider it. We look for other causes. But there are so many drugs that can induce thrombocytopenia. On this site, we have description of more than 300 drugs which can induce thrombocytopenia. And the mechanisms by which these drugs are producing thrombocytopenia are mainly 2. Either they suppress the bone marrow production of platelets, either they will induce the formation of antibodies which will act and destroy the platelets only in the presence of the drug. What is to be done in this case? We should stop the drug if it is possible, and we should see an increase in the platelet counts in a few days. Thrombotic microangiopathies. This is a not so common cause of thrombocytopenia in ICU patients, but the problem is that if we don't know about it, then we don't think about it. And if we miss it, the patients will probably die, and this is a hematologic emergency. Thrombotic microangiopathies means that we have thrombosis in some small vessels, especially in vessels with a high shear stress, leading to organ dysfunction. And mainly, the most common organ dysfunctions in this situation are neurological, renal, or gastrointestinal symptoms. Of course, we can have also other organ dysfunctions, but this is the most common. We have to consider thrombotic microangiopathies when we have thrombocytopenia and microangiopathic hemolytic anemia. When we see this, then we have to think that we might have thrombotic microangiopathy. And there are 3 main types of thrombotic microangiopathies. One of them, hemolytic uremic syndrome, is exclusively due to infection. And this occurs especially in children which have previously an episode of diarrhea. Atypical hemolytic uremic syndrome occurs when we have a complement dysfunction, and thrombotic thrombocytopenic purpura, TTP, occurs because of ADMTS13 deficiency. ADMTS13 is the enzyme responsible for the cleavage of von Willebrand factor. And these 2 can either be congenital or they can be acquired. They are acquired when we have also some associated conditions in patients that have immunological problems, in patients that underwent organ transplantation, bone marrow transplantation, or they have infection. So the patients usually have really, really serious health problems in order to develop these things. TTP. This has a very interesting physiopathology. This is the normal blood flow, and as you can see here, the endothelial cells produce these von Willebrand factor multimers, which are cleaved by ADMTS13 to pieces. And this is the normal situation. But if we don't have ADMTS13, we will have these von Willebrand multimers, which will be formed by the endothelial cells, will not be cut down and will remain there, and under shear stress will expose the platelet binding sites, and we will have the platelets binding to them and forming the platelet clots here. And this will almost obstruct the microcirculation. And we have the blood flow coming, and the erythrocytes will bump into these blood clots, into these platelet clots, and will form pieces. And this is why we have anemia, this is why we have hemolysis, and this is why we will see these pieces of erythrocytes on the blood film in TTP. So, as I said, this is an emergency. So once we have thrombocytopenia and we have proof of hemolytic anemia and the presence of these fragments of erythrocytes on the blood film, schistocytes, then we need to suspect TTP, and we don't have to waste time. Of course, we take some blood samples in order to run some other tests, but we don't have to wait for the results of the test. We need to start immediately with the treatment. And the treatment is plasma exchange. Of course, it includes also corticosteroids and other stuff, but our main job as intensivists is to start plasma exchange. If the patients present with a history of diarrhea, we need to order Shiga toxin testing if we have still patients producing stool. As I said, we have three main types of thrombotic microangiopathies. This one, due to infection, is very easy to diagnose because the patients are usually children, come with a history of diarrhea, so this is easy to diagnose from anamnesis. The differential diagnosis between TTP and atypical hemolytic uremic syndrome is not so easy, and it's based on the level of activity of ADMTS13. The problem is that this level of activity we cannot measure on many occasions in our hospitals, and if we ask in a different lab, it takes quite a while until we get the result, and this is why we can run instead a score which is developed, and this scoring system, such as plasmic score, but there are also other scores, can predict with a very good sensitivity and specificity ADMTS13 less than 10% or TTP. As I said, this is hematological emergency. Without treatment, the mortality is 90%. With treatment, it can be reduced to 10 to 20%. So we don't have to wait anything anymore, any blood tests, and we need to start plasma exchange treatment. We need in the first 3 days to exchange 1.5 plasma volumes per day, and then 1 plasma volume per day. Of course, we have other treatments, but these are usually recommended by the hematologists. So this is our job as intensivists. Just one thing to mention, these patients, of course, come to us with a low platelet count. We don't have to be afraid to put the CVC and dialysis catheter on, because these patients usually do not bleed, they are more prone to thrombosis. So this is why we don't give prophylactic platelet transfusion in these patients. We just do our job and insert the catheter and transfuse platelets only in case of life-threatening bleeding. And something else, when we have the platelet count already started to increase more than 50 giga per liter, we need to give already thromboprophylaxis in these patients because they are very prone to thrombosis. After starting plasma exchange, we expect the platelets starting to increase in 3 to 5 days. If they don't increase, then we are in trouble. It means that either we have refractory TTP and we need to supplement our treatment, either it means that we are not on a good diagnosis and we have atypical hemolytic uremic syndrome, and we have to give also another treatment. Since last year, we have another treatment which is approved, and this is something very intelligent, very clever. It is called caplacizumab, and it is an antibody which inhibits the connection between von Willebrand factor and the platelets. So this antibody will limit the formation of the clots and will limit the organ dysfunction. So the treatment now, starting with last year, includes this antibody, plasma exchange, and immunosuppression. Heparin-induced thrombocytopenia. This is another cause of thrombocytopenia that we see in ICU. Actually, this is not so common cause. In ICU, we see it in about 0.5 to 1% of the patients only, but the real challenge is to find out which are the patients that really have HIT from all the patients in ICU having thrombocytopenia and receiving a form of heparin. This is an immune-mediated response to heparin treatment, and it is due to the formation of antibodies against a complex formed by platelet factor 4 and heparin. So platelet factor 4 is something that is released from the platelets, and it is positively charged. Heparin, as we know, is negatively charged, and this is why heparin will bind to platelet factor 4. And this complex will be stuck on the surface of platelets, and it might lead to the formation of antibodies against this complex, which will also bind to the platelets and will lead to increased platelet removal by macrophages, leading to thrombocytopenia, but in the same time will lead to platelet activation, release of microparticles, and platelet aggregation, leading to thrombosis. Arterial thrombosis and venous thrombosis, both. Typically occurs in the 4th to 15th day after the start of heparin treatment. It can occur even earlier if the patient received heparin in the previous month. As I said, it is not very common to see such thing in ICU patients because we might suspect it because we have patients having thrombocytopenia very often and they all receive a form of heparin in the end. We can suspect it, but only a few of these patients really have HIT. And in order to diagnose them, we need to make this 4T scoring system. It is called 4Ts because the 4 criteria begin or contain the letter T. The first one is thrombocytopenia. So typically in HIT, we have half of the platelets decreasing, but usually not to a very low nadir. Usually the nadir is higher than 20 giga per liter. Second T is timing, as I said, occurring between 4th to 15th day after heparin exposure. The third T is clinical manifestation. We have thrombosis, either arterial or venous. And the fourth T actually is not a T, comes from other causes of thrombocytopenia. This is not very useful, in my opinion, in ICU patients because in ICU patients, we always have another possible explanation of thrombocytopenia. As I said, drug-induced thrombocytopenia we need also to consider. But anyway, we run this score and we obtain the result, which can be either high, intermediate, or low probability according to the number of points. And with this result, we go into an algorithm. So we calculate the score. If we have a low clinical probability, so a score equal or less than 3, then we can forget about HIT. The patients do not have HIT, we can continue with heparin. And of course, in this time, we have to investigate for the real cause of thrombocytopenia in our patient. So this 4T score has a very high negative predictive value. If it is less than 3, no HIT. If it is higher than 3, then the patients probably have HIT. So in this case, we need to stop heparin and we need to start a non-heparin anticoagulant. If we have only intermediate value, and we are afraid that the patient might bleed and we don't know for sure that we really have HIT or not, then we can compromise a little bit in this patient and only give prophylactic dose of non-heparin anticoagulant. But this is the only scenario when we give prophylactic dose. In the other patients, we need to give therapeutic intensity. The problem is that this 4T score has not a very good positive predictive value. So this is why we don't stop here. This is why we need more tests in order to confirm the diagnosis. And the next step is the immunoassay. It means that we try to find the antibodies against heparin platelet factor 4 complex. So we move forward, we get the immunoassay. If it is negative, this immunoassay, because it has a very good sensitivity. If it is negative, again, we forget about HIT, we can continue or go back to heparin. And in the same time, we investigate patients for the other causes of thrombocytopenia. If the immunoassay is positive, so we have antibodies against the complex formed of heparin and platelet factor 4, then it is possible that we have HIT. I say it is possible because this immunoassay has a very low specificity. So even if it is possible, does not necessarily mean that the patient has HIT. We only suspect it. But in this case, we need to give non-heparin anticoagulant, this time at therapeutic intensity. It is mandatory. And we have to move forward to obtain the next step of diagnosis confirmation, which is the functional assay. And I will explain immediately why. By the immunoassay, as I said, we identify the antibodies against platelet factor 4 and heparin. And actually, these antibodies are formed in a very, very large number of patients. And different types of antibodies are formed, as you can see here. But only a small amount of these antibodies will actually bind to platelet and activate the platelets, leading to thrombocytopenia and to thrombosis. All the other antibodies are just formed, but they cannot bind on the platelets, and they do not induce HIT. And by running the functional assay, we only identify these antibodies, and this is the gold standard for the diagnosis of HIT. So we obtain the functional assay. If it is negative, we exclude HIT again. We can restart heparin. If it is positive, then we have HIT, and we need to treat our patients accordingly. This means giving non-heparin anticoagulation, and these are the drugs which are recommended in the last guidelines published last year. So as you can see, we have some drugs which we can give in IV infusion. We can give some of them fondaparinux subcutaneously, and others we can give orally. Of course, in critically ill patients or in unstable patients or in patients that have a high bleeding risk, we prefer this IV infusion because we can stop it and we can do something which is necessary if the patient is bleeding. If we have liver dysfunction, we prefer bivalirudin. We try not to use argatroban. If the patients are clinically stable, then they can receive DOACs or fondaparinux. But if the patients already present with a very extended thrombosis, then we try not to give DOACs because there are not so many reports regarding the efficacy of DOACs in these cases. We prefer fondaparinux or the IV drugs. What we don't have to do in HIT, we have three major don'ts. We do not give warfarin from the beginning. And if the patients already come on warfarin, we stop it, we give vitamin K, and we forget about warfarin for the acute phase of HIT. We don't give prophylactic platelet transfusion because this is a mainly prothrombotic disease. Even if the patients have low platelet counts, we don't give prophylactic platelet transfusion, only in case of bleeding. We don't insert inferior vena cava filter because it will lead to limb necrosis, thrombosis, and patients will lose the limb. How long do we anticoagulate these patients? If we have thrombosis, it's recommended to give 3 to 6 months. If we have only HIT without clinical thrombosis, then it is recommended to give it until we have platelet count recovery, usually less than 3 months. Of course, we cannot leave the patients for 3 months with IV or subcutaneous treatment. We try to switch to an oral agent, and it is now recommended to switch to DOACs once the patients are stable. And we can switch immediately as patients are stable, not in ICU anymore, just on the ward. And we don't need to overlap with other non-heparin anticoagulants. If we don't have possibility to give DOACs and we only have warfarin, we can only give it when platelet counts are recovered, and we need to overlap with parenteral non-heparin anticoagulant. It is more complicated management. As you can see here, after the acute HIT, we have different subacute phases, and then we have the remote HIT where platelet count is recovered and both assays are negative. The question is, and the big problem is when we have a patient having these phases of HIT, which will need re-exposure to heparin, what we do with this patient? For example, in cardiac or vascular surgery where we need to give heparin mandatory, we would try to delay the surgery until we have the negativation of the functional assay. If it is not possible, then it is recommended to do the surgery with intraoperative bivalirudin. If you don't have it in your hospital, you can give intraoperative heparin, but only if you did plasma exchange before to remove the antibodies, or you can combine it with a very powerful antiplatelet agent, such as tirofiban. And here you can see in these guidelines different recommendations if you have such patients. Luckily, it is not so often to have such patients in subacute phases of HIT that need heparin re-exposure. But what you can have is patients that have remote HIT, so means that they had HIT documented, I don't know, 1 or 2 years before, and they come to you for surgery. And you need, of course, to give thromboprophylaxis in these patients. The question is what you give. It is recommended to avoid giving thromboprophylaxis with heparins, but to give thromboprophylaxis also with non-heparin anticoagulants, even in this phase of remote HIT. So in a patient with a history of HIT. And I think this is very useful recommendation. Now let's talk a little bit about the numbers, because we know that platelets are low in ICU patients. The problem is when we need to give prophylactic platelet transfusions, before which maneuvers we need to supplement the platelet counts. We know that bleeding, spontaneous bleeding, does not occur unless we have less than 10 giga per liter platelets. So if we have less than 10 giga per liter, we can give prophylactic platelet transfusion because we are afraid of the risk of spontaneous bleeding. Otherwise, no. For CVC line placement, it is recommended to have 20 giga per liter. For major non-neuraxial surgery, 50 giga per liter or liver biopsy. And for surgery, neurosurgery or posterior eye surgery, more than 100 giga per liter. In septic patients, we have the same recommendation, no prophylactic platelet transfusion unless platelets are less than 10 giga per liter, or if the patients have a very high bleeding risk, we can give if they have less than 20 giga per liter. Acquired von Willebrand syndrome, this is something that I will just say a few words about because it used to be very rare disease. It means that we have problems either in the amount, either in the function of von Willebrand factor leading to bleeding. And usually we have the congenital form, but now we get to see more and more often this acquired form because we get to see more and more patients on cardiac assist devices. And this will lead to the destruction of von Willebrand factor and will lead to bleeding. Actually, this acquired von Willebrand syndrome occurs in about 1/5 of all von Willebrand disease patients. And we can see it either in patients with hematological disease, because in these patients we have antibodies formed against von Willebrand factor, which will destroy it, or we have the absorption of von Willebrand factor on the surface of malignant circulating cells. Or we get to see it in cardiosurgery patients. For example, if we have very tight aortic stenosis, we have this von Willebrand multimers, which is normally circulating in this coiled form. Due to high shear stress, will uncoil and will expose the ADMTS13 cleavage sites, and ADMTS13 will come and will destroy this von Willebrand factor in the circulation, cutting it to pieces, and this will no longer be functional to realize hemostasis, and we will see bleeding. This is something similar that we see in patients that have mechanical assist devices, cardiac assist devices. This is LVAD. As you can see, normally we have these coiled multimers which enter into the device, but because of the high shear stress, they will uncoil and they will be cleaved by ADMTS13. So if we see bleeding in such a patient, we have to think also about this acquired von Willebrand syndrome. And it is not very difficult to diagnose if you have help from the lab. You just have to measure von Willebrand factor multimers, and you will see them low, and then to ask for von Willebrand factor activity, and this will also be low, and you have the diagnosis. The treatment would be basically by treating the underlying disease, trying to replace von Willebrand factor if the patients are really bleeding, or you can try DDAVP as you heard in the lecture before by Sibylle. Regarding the problems related to plasmatic coagulation, this time in ICU, similarly to thrombocytopenia, ICU patients usually we see very often about 1/3 of them having plasmatic coagulation problems. And as you can see,
from this slide, actually, the increase in standard coagulation tests, the increase in prothrombin time, the increase in INR is also correlated to patients' outcome, similarly to thrombocytopenia. The question is, do we have more bleeding in these patients where we have this prolongation of the standard coagulation tests? And actually, the answer to this question is no. I will show you this study. This is a study in ICU patients having prolonged INR, good platelet count, and they were submitted to tracheostomy. In these patients, they did not correct the values of INR if ROTEM was normal, and they had no bleeding complications. So it seems that this prolongation in the standard coagulation test in ICU patients is predictive of outcome, but not predictive of bleeding. However, these patients in ICU, we see very often that they do receive FFP in order to correct their prolongation of standard coagulation tests. And in order to believe in this paradigm of prophylactic plasma transfusion in ICU patients, you have to believe in 3 sentences. You have to believe that elevated PT increases risk of bleeding, then that if you transfuse FFP, you correct the PT, and if you corrected it, then the patients will not bleed anymore. So if you have all 3 sentences fulfilled, then you have an excuse to give FFP to correct coagulopathy. Regarding the first one, elevated prothrombin time increases the risk of bleeding. No, we all know it is not true. And we know this from many studies, and this is a meta-analysis showing, comparing the bleeding between patients with abnormal coagulation and normal coagulation undergoing different invasive procedures. No difference in bleeding. Let's move to the second one. Transfusing FFP will correct the INR. Well, it depends. It depends on the amount of FFP that you give. It depends on the weight of the patient, and it depends on the level of coagulation factors that you start with. And you see this nice cartoon. We have on y-axis, we have the level of coagulation factors. We know that if we have lower than 30%, then we have impaired hemostasis. And on the x-axis, we have prothrombin time. If we give this amount of plasma, starting with very low coagulation factor levels, as you can see, we have a good improvement in prothrombin time. But if we give the same amount of plasma in the same patient, but starting with the higher coagulation factor levels, the improvement in prothrombin time is not at all significant anymore. And the third one, if we corrected the INR or the PT, we will have less bleeding. I will show you this study. This is a randomized trial, but we have this data, similar data also from many, many observational studies. In this study, they included non-bleeding ICU patients with prolonged INR, which were supposed to be submitted to invasive procedures, and they divided them in 2 groups. One of them received FFP, one of them did not receive FFP. No differences in bleeding complications. So it seems that the correction of the INR does not influence the risk of bleeding, of course, in patients not on vitamin K antagonists. However, it seems that still, even we have all these proofs, it seems that still a lot of patients in the ICU receive FFP, and this is a study showing that 13% of all ICU admissions, and this is in UK, received FFP. The problem is that many of these patients received FFP in the absence of clinically significant bleeding and also having very low, even normal values of INR. We know that we have prolongation of standard coagulation tests. We know that we have thrombocytopenia in critically ill patients. So the question is, how do we assess coagulopathy in these patients if these tests do not help us? The recommendation is to use viscoelastic methods and aggregometry and to base our treatment with blood products on these results. And the last recommendation is that the use of standard coagulation tests is not recommended to assess bleeding risk, and we should not correct the increased value of standard coagulation tests with FFP in the absence of bleeding and in the absence of treatment with antivitamin K. And the final thoughts would be that, as we know, we have in ICU patients very often prolongation of standard coagulation tests and thrombocytopenia, not necessarily related to the risk of bleeding, but related to the outcome. So we should not just treat them in the absence of clinical manifestations, and we should base our treatment on algorithm, including point-of-care testing. Thank you.